to offer any information that will help you. At Kindbody, our mission is really that we want to revolutionize fertility care by delivering an unparalleled patient response. And what's really interesting about Kindbody, I've been in the field for 30 years. What's interesting about Kindbody is the leaders have really worked to democratize access to care, meaning having unique employer benefits, going to the employers and getting them to sign up for fertility benefits for the employees within the companies. And that's something that's unique. Most people get their fertility benefits through an insurance company rather than direct to employer. And, we're really changing the landscape of how fertility is being delivered. One family, one community, one baby at a time. Next slide. What do we do? I can't go into everything that we do, but we basically do everything. We do fertility assessments, we do inseminations, we do IVF, we do egg freezing, sperm freezing, embryo freezing. We take care of all kinds of people. We don't discriminate against any kind of relationship or single person trying to have a child. We offer male reproductive health, genetic testing. We have some at-home tests that are pretty unique. There's an egg donor bank that's coming online now. So we'll have donors that we stimulate ourselves and have them. There's some wellness and nutrition and mental health activities that also go on, and people can take part in them if they desire. Next slide. Well, in 2022, there are still 3 major components to create a child inside the body. One is the egg. One is the sperm, and one is somewhere to carry that pregnancy, which is the uterus, and it has its associated fallopian tubes that allows the sperm and egg to come together in the body. Next slide. So let's start with the egg. A person that's born with ovaries is born with all the eggs they ever have. In fact, at 20 weeks in utero, all the eggs are made, and the ovaries contain about 6 to 7 million eggs at 20 weeks in utero. And by birth, once the fetus comes out of the body, there's only about 1 to 2 million eggs left. So it's pretty amazing that the fetus can exert that much energy to create, the reproductive tissue within the ovary. And then by the time the child is born, it's lost about 6/7 of those eggs. It's not really clear why there's so much, but obviously that egg is really important and has really important mechanisms and tissues within inside. By the time a person ovulates, by the time a person ovulates or goes through puberty, there's about 300 to 400,000 eggs left. So you lose a lot of eggs from birth to puberty. And again, it's not clear why that would happen, except for that eggs just die out. From the minute they're born, they die out. And at each month, whether, in a woman's or a person's life who has ovaries, whether you're on birth control, you're pregnant, you're getting periods, or you're not getting periods, about 1,000 eggs are lost each month. And the number of eggs that are lost goes up as a person ages. So for instance, you lose more eggs each month when you're 38 than say when you're 20. And important to state at this point is that the rate of ovarian aging is variable from one person to another. So some people are much more fertile at say 38 or 40 than another person. Next slide. So how do we evaluate that? Well, thankfully, we have tests that we can do at the baseline. And whether it's baseline in the cycle or not, there are tests we can do. So at the beginning of the cycle, one can do blood work that is called the follicle stimulating hormone and estradiol level. Anywhere in the cycle, someone can do what's called an anti-Müllerian hormone, which is a hormone secreted by the ovary and looks at the quantity of the eggs in the ovaries. And a transvaginal ovarian ultrasound can be done. Most efficient to do it at the beginning of the cycle, and you look to see how many antral follicles are present, meaning the number of follicles that are seen in each ovary with eggs that are sort of ramped up, ready to go. Next slide. So this is an image of a sonogram image of an ovary. So you see the ovary with all those antral follicles. This is somebody who has more antral follicles than we usually see, but each of those black circles represents an antral follicle. And within those antral follicles, each one has an egg. And the egg, if you're thinking about how big an egg is, you take a pencil and make a dot on a page, And that's how big the egg is. So you can actually see it under the microscope when we take it out. And you can see it with the naked eye if you look very carefully. And we do this every day when we do in vitro fertilization. In general, people have about 4 to 8 antral follicles in their ovaries. And for however the body figures it out, it picks one of those antral follicles and that ovulates in a natural cycle. We don't know how it picks, say, left, right, but it tends to go back and forth, left, right. And when you take one ovary out, like say a woman has an ovarian cyst, or a person with ovaries has an ovarian cyst and has to have their ovary removed for some reason, the other ovary that's there will ovulate every month, which is pretty amazing. So it's a sort of like a clock going on inside the woman, and it's driven by areas of the brain. Next slide, please. When getting pregnant naturally, the egg is released from the ovary. The ovary is that white structure on the left side of the picture. It's released into the end of the fallopian tube. And actually that fallopian tube isn't sitting on the egg like that. It's kind of sitting next to it. And so it's like a little vacuum, and it's kind of amazing. I've operated a lot in my life, and you look at that fallopian tube and you're like, how does it pick up the egg every month? But it does. It's literally like a little vacuum. And at the same time, if someone's trying to get pregnant and has conjugal relations, with someone who has sperm, then that sperm swims up through the fallopian tube, meets the egg near the end of the fallopian tube, and then once fertilized, that embryo is pushed back to the uterus with these little hairs on the inside of the fallopian tubes called cilia. They're kind of just like sweeping wave, and they push the embryo back over the course of a few days. And once that embryo gets to the uterus, the embryo usually is the one that decides whether it's going to stick or not. Some people have problems with their uterus, but most times when an embryo doesn't stick, it's because of the embryo, not the uterus itself. Next slide, please. So why do we get nervous at the age of 35? I have to say, when I was a resident, they used to call women who were in labor elderly primips if they were 35 or older. I just cringed to think I used to write that in the chart, but that was the term that we used in the 80s. And the reason for that is that over the age of 35, it's harder to get pregnant. We just know that. And more pregnancies go awry, meaning more miscarriages happen. So we have to be more careful about, in our thoughts about pregnancy after the age of 35. Literally up to the age of 35, people are almost as fertile as when they're 18 to 20. But once 35, 36, 37 roll around, each of those years, you lose about 15% of your fertility. So 35 to 36, 15%, 36 to 37, 15%. So by the end of 35 to 40, you've lost about 2/3 of your fertility. And that's the scary thing. You don't feel it. You can be running, you can be exercising, doing Pilates, yoga, whatever, and you feel as healthy as you can be, but your ovaries are still not doing what they were doing when they were younger. Next slide, please. So we try to look at the egg quality and the egg number, and we know from evaluation, either through in vitro fertilization, where we're actually looking at the eggs in the dish, or we're stimulating the ovaries and trying to get more to produce, or we're doing blood tests to look at how the ovarian reserve is. We know that as a person gets older, both the quality and the quantity decline. And poor egg quality is often what leads to embryos not able to create a live birth. For instance, if the chromosomes don't line up correctly and there's an extra chromosome there, or a missing chromosome, which often happens as you get older, that embryo most often won't stick to the uterus, or if it does, it will usually miscarry. When we look, even in the early days of doing testing of embryos, we saw that when a woman was 40, that only 1 in 10 embryos is chromosomally normal that is tested. And when you're 30, it's 1 in 3 embryos, or 1 in 2 embryos is chromosomally normal. So you just lose this incredible potential of the actual ovary to egg to become a live birth from the ages of 30 to 40. Next slide, please. So talking about abnormal chromosomes, the term for that is called aneuploidy. It just means there's a wrong number of chromosomes within the embryo. So I don't know if you remember from high school or whatever you took biology, but you have 23 pair of chromosomes. and they literally line up in a row. And if there's an extra chromosome, for instance, one that people know is trisomy. So trisomy 21 is Down syndrome, just to give you an idea of one aneuploidy. And if you look at this graph, you see with age, aneuploidy goes up tremendously. So you look at 41 to 42, it's up in the 90% range. So that's why you get only 1 in 10 that's normal, and why you don't want to wait to that age necessarily to have a child. Next slide, please. Switching gears, looking at other issues related to ovary function. Most of these are hormone related, meaning a woman can have too much hormone. Polycystic ovary is a lecture all unto itself, but women have too much hormone coming from the ovary. You can have too much or too little hormone coming from the thyroid. You can have too much from the thyroid gland. You can have too much prolactin coming from the pituitary. You can have not enough hormone coming from the pituitary, or you can have ovarian failure altogether, where your ovaries aren't working anymore earlier than it should. So we see all these things. I mean, the most common one I see in New York is polycystic ovary. There's a lot of polycystic ovary in New York. They say 20% of women in New York City have polycystic ovary, and it's not from living here. It's not the air or taking the subway. It's just the genetic mix of people that live in New York. Next slide, please. Switching to the uterus and fallopian tubes, if you look at the picture on the left, this shows a woman cut down the middle, like cutting down through your, say, your nose to your belly button and that way. And you see the uterus in the middle. That's that pink structure that holds the pregnancy. And then if you look at the right image, it's looking at your uterus face on. So looking at your belly, like from your belly button down, and looking at what's there to carry pregnancy. So the uterus is basically a muscle. It's a muscle. It's there to stretch and then push the baby out. And it's connected to the fallopian tubes, like I showed before. And the ovaries are adjacent to the ends of the fallopian tube to allow the eggs to release into the fallopian tube. Next slide, please. Looking at what happens in the ovaries, if you're a normal ovulatory person, about once a month, you will release an egg from the ovary. That's called ovulation. And it happens as a cycle. Again, it's a clock. It's driven by the brain. And it's a clock that's sort of ticking slowly in the brain and causes hormones to be released in a concert that causes the egg to be released, and amazingly also gets the uterus lining ready for implantation every month. So literally from the age of 13 to about 45, 47, 48, depending on your genetics, you're releasing one egg. So you release an egg about 450 times in your life. And when you release that egg, the lining has been getting ready, and then it really gets ready for implantation in the phase right after the egg releases. Next slide, please. What things can be problems? Well, in the fallopian tubes, we don't see it as much anymore, but honestly, when I was a resident, there was a lot of chlamydia in America in the 80s, a lot. I mean, there still is chlamydia, but there was a lot of untreated chlamydia. So we had a whole ward in the hospital. I worked in one of the big hospitals in New York City, and we had a whole ward that was just called pelvic inflammatory disease, PID, and people were in there getting IV antibiotics for chlamydia and associated infections. And now we don't see that so much anymore. Like people, one can get treated outpatient, but we don't see this really severe fallopian tube damage that we used to see. But the other thing that can damage fallopian tubes besides infection is endometriosis. So endometriosis is a disease where the lining of the uterus gets out from the ends of the fallopian tube into like the pelvis and kind of wreaks havoc. It makes scar tissue, inflammation, and it can make the fallopian tubes get swollen. Sometimes I've operated on people and they're almost indiscernible. It can be, the inflammation can be so bad. So there are ways we can check the uterus and the fallopian tubes to see if the structure is okay. And that is with either a hysterosalpingogram, which is a dye test where you're on an X-ray table, or a saline infusion sonogram, which is a test where you put a little plastic flexible catheter into the uterus and put some water in, and you can capture images with sonogram. And we use that a lot. I even do saline sonograms more than I do histograms, and I used to just almost exclusively do histograms in the 90s and early 2000s. The sonogram images have gotten so much better. Next slide, please. So this shows, again, this is cutting something down the middle. So it's like if you took an apple and you cut it down the middle and you were looking where the seeds are, that whiter area in the middle of the uterus is called the endometrial lining. So the uterus lining gets ready, and we can actually see this. I look at this every day. We can see the lining get ready for implantation. The estrogen that you're releasing when you're getting the egg ready is also beefing up the uterus lining to get it ready for implantation. And then after you ovulate, that cyst where it was producing where it's maturing the egg and releasing estrogen actually becomes a progesterone factory. So we have areas in our ovaries that actually go from producing estrogen, popping an egg out, and all of a sudden the factory turns to progesterone. It's really kind of miraculous that that can happen. And then it goes back to producing estrogen the next month. So it's just this cyclic kind of miraculous structure that gets the egg ready and the uterus lining ready for implantation every single month you ovulate. Next slide, please. This we talked about a little bit already, that with the way you evaluate the uterus is by either putting water in and looking by sonogram, which is that black image. And in that black image, you can see there's a lesion inside the uterus. It should be all black, and that sort of grayish looking thing is a polyp that's growing inside the uterus. Sometimes you see fibroids inside the uterus, and it's really helpful because some of these lesions we can remove just by doing what's called hysteroscopy, where we put a little instrument inside the cervix and we can actually see the lesion and pull it out. And we do that a lot. I do it at Bryan Park every week. So, I mean, I've been doing that for really 35 years. So it's pretty amazing. Next slide, please. It's amazing and easy, which is good. Looking at abnormal shapes in the uterus, actually, one of the patients I'm operating on tomorrow has what you see on the left side, which is a uterine septum. So she has a divider. It's almost like a big icicle hanging down the middle of the uterus. And the problem with a septum is, one, it divides the space. It makes the space smaller for a baby to be, sort of developing there. But two, that little tongue that's hanging down has less vasculature. So it's harder for the placenta to spread and sort of get blood supply from the uterus. So we can cut that little area out. I mean, I'm literally doing it tomorrow. A bicornuate uterus is a variation on that, where if you look on the outside of the uterus, it's heart-shaped like the inside. That's not so easy to repair. That you have to do with a bigger operation, but septum are much more common than bicornuate uterus. And I bet I've repaired 1,000 of them in my lifetime, something like that. Next slide, please. Sperm is a pretty easy analysis. A semen sample has to be produced, and then we can look at it for different areas of quality. So we look at how many sperm are there. We like to see about 15 million sperm per cc. We see how many are motile. We like to see about half of them swimming. And we look at the shape of the sperm. We look to see, like, this picture has different variations, and I've seen all these variations, but quite frankly, when there's, say, 20 or 30 million sperm, the morphology isn't so important, because of the whole set of, say, 20 million sperm, there's enough normal sperm in there that one of them will make it to the egg. Next slide, please. Kindbody does have male reproductive health specialists. So if we do see something wrong with the sperm, we will refer you for that. And I'm not really going to get into all that. That's another lecture unto itself. But there are different reasons that the male reproductive specialist would speak to someone about the sperm. Next slide, please. Female testing, when one is doing any kind of fertility treatment, in general, we make sure your pap smear is up to date, you've had a physical exam, you've had a breast exam, there's some hormones we check, infectious disease of both parties, if there are two parties, and if a donor gamete is used, that party is also screened for infection. We recommend genetic carrier screening, although it's not mandatory. There's genetic carrier screening where you can look to see if you're a carrier of, say, cystic fibrosis or Tay-Sachs, and say if two people are trying to make a child and you both carry it, that's something we talk to you about, because that can be tested in the embryo. We look to make sure you have titers for some of the childhood diseases, measles, things like that. And if you're not immune, we'll talk to you about vaccines. Next slide, please. Genetic carrier screening is, as I said, if both parties are carriers for the same disease, there's a 25% chance that you'd have affected child and 50% that your child would be a carrier. So we do want to know these things if you're going to create embryos. Although I will put a caveat there, it is not necessary to do genetic carrier screening. It's just something we recommend. Next slide, please. One important thing when considering what you're going to do if you're going to have fertility treatment is, what are your goals? Like, what are you looking to do? Most people who come to the clinic looking for fertility care at least say, I think I want to have a child in the future. Some people say, I don't know if I want to have a child, but I want the option to have a child if I decide I do want a child. That's probably the lowest denominator of what I see of people who are coming to have fertility treatment. And it ranges all the way to people saying, I've wanted a baby for the last 10 years and we've been trying and it's not working. I mean, I literally see people, I say, oh, you've been married 20 years and trying 10 and you're just coming. And yep, that's just the other extreme of people showing up and wanting help. So we really want to know, do you want to get pregnant? Do you want to get pregnant soon? If you're not going to get pregnant soon, do you want to try to preserve your fertility? You know, think about, what is your dream family? Do you want more than one child? Because if you want more than one child and you're 35, you might want to freeze something even before you try for that first live-born child, because as probably most people in this seminar know, it takes 9 months to have a child. I always laugh because when I was a fellow, I did research with worms, the C. elegans, and their gestation is 12 hours. I thought, why don't we have a 12-hour gestation? That would be a lot easier. You know, you could certainly wedge that into your life a lot easier than 9 months. But all kidding aside, when you think about a 9-month gestation, and then usually you're not going to want to have a child within the first 2 or 3 months after, or maybe you want to nurse, or maybe you just want to get some sleep. You know, a couple of years go by between each child. And so time can go pretty quickly if you're just starting at, say, 33, 35, 37. So that's why sort of gauging, like, what is it you want, helps us to decide what's best for you. Next slide, please. What is the definition of infertility? What does it mean to be infertile? Well, infertility is defined as the inability to get or stay pregnant after trying for 1 year. And most insurance companies will shorten that. So the definition of infertility doesn't change, but over the age of 35, most insurance companies will say, yes, you can actually get help with your fertility if you've been trying for 6 months. And quite frankly, many of the insurance companies don't even demand a certain amount of time. They just say, if the fertility doctor feels that you would benefit from fertility treatment, they often will allow it if there's some factor that we find. In general, 1 in 8 couples experience infertility. And about a third of cases are male factor. So it's important, if there is a male in or a person with sperm in the mix, that we actually check that sperm and make sure that that's not the primary factor, because that often takes us in a different direction and often takes us to even in vitro fertilization. Next slide, please. So what is IVF? I would guess most people on this seminar know what IVF is, but it's where you create the pregnancy outside the body. So in vitro is outside the body, basically. And it's in vitro fertilization means we're putting the sperm and egg together outside of the body. So we're literally putting them together in a dish and then putting them in an incubator to grow. So normally the body will mature 1 egg to release in a month. And we will give fertility drugs that make, say, 5 or 15 or even 20 eggs come out at one time. And then we'll fertilize those eggs in the dish and let them grow. Next slide, please. What happens with the injections? You're like, what injections, right? I'm just thinking about when I was walking up to medical school and I thought, oh, this will be fun. And the next thing I knew, 10 years had gone by. It was fun, but it was 10 years. But thinking about the injections, it's a little bit of a mountain like that, where you're like, oh, okay, I don't usually do injections. And now I'm going to do injections every day for 10, 12, 14 days. It's a lot, but I have to say it's not insurmountable. And after doing 1 or 2, there's shots that you do just under your skin. They're not deep shots. And so after you do a few, most people are like, okay, it's annoying, but it's not so bad. During the course of the shots, you have to come in and get monitored. So you have to have fertility monitoring of the ovaries. The most important reason to monitor is to make sure that the ovaries don't get too stimulated, meaning we don't make too many eggs, because that can be associated with, say, fluid retention. And in the worst cases, you can even be short of breath. And we really try to avoid that. So we monitor you carefully to make sure we don't get into what's called severe hyperstimulation. But we also are monitoring how many eggs and how much drug to give you. So we might say, okay, you come back in 2 days. And then in 2 days, we do another blood test and ultrasound and say, okay, here's your dose for 2 days, come back again. So it's kind of a like wait and see as you're going. And then once we think the eggs are ready, then we'll schedule the egg retrieval. Next slide, please. This is just saying that we have weekly med teach sessions. So we actually teach you how to do the medications. If you're going through treatment, we'll go through that with you in detail. Next slide, please. So what is the egg retrieval? The egg retrieval takes about 5 to 10 minutes, and it's most often done under light anesthesia, meaning you have an intravenous put in, intravenous catheter into your arm most often, and the anesthesiologist will give you some light sedation. It's kind of like having a couple cocktails really quickly and going to sleep. And but the nice thing about anesthesia is you wake up really quickly. Like you'll go to sleep for 5 to 10 minutes and then you're awake in about 2 minutes. So it's all really fast. And during the procedure, a narrow needle is placed through the vagina wall into the ovary. So that's why we give you the sedation. It actually doesn't hurt that much. And I've done quite a few procedures awake, for instance, for cancer patients who can't tolerate anesthesia. But we put that needle through the top of the vagina, and the ovaries are literally sitting right at the top of the vagina. And if we put that needle that's hooked to suction into the follicle, it'll aspirate out the fluid and the egg will pop off the wall. On average, we get about 5 to 15 eggs. Really is age dependent and genetics dependent, sometimes more, sometimes less. And some of the testing we do beforehand gives us an idea of what you might have, like your AMH and your AFC level, your antral follicle count might give us an idea. But I always tell patients, I don't really know what you're going to have. It really depends. We have to wait and see how you respond to the medication. Next slide, please. After the retrieval, the eggs are placed with sperm in a dish. So it's literally a plastic dish that's on the counter, and it's on a very special counter that's body temperature. And then once the sperm and egg are together, we put them in special media that helps them to grow, basically nutrition. And then we put that in an incubator and we leave it there for 5 days. So we actually don't look at the embryos very much from day after we see if it's fertilized or not, until the day that we're looking to see if we're going to transfer them, biopsy them, or freeze them. And at that stage, it's called a blastocyst. So on the 5th day after the eggs are retrieved, we see a blastocyst that actually literally has a little cyst in the middle. That's why it's called a blastocyst. And it has a very defined character where some of the cells become what's called the inner cell mass, or what will become the baby. And the outer cells actually have already defined what will become the placenta. Next slide, please. That's a blastocyst on the right side. So if you look at that, you probably can't see it that clearly, but in the middle, there's kind of a little glob of cells. That's actually what becomes the fetus. And all those cells around the outside are called the trophectoderm, and they actually become the placenta. So already 5 days after coming out of the body and being fertilized, the cells have differentiated into what they will become. A lot of people who are doing IVF today are testing the embryos to see if they have the right chromosomal complement. Do they have 23 pair of chromosomes? And when you do that, you see the little catheter that's next to the blastocyst on the right side can actually aspirate out a couple of those cells that become the placenta, the trophectoderm, and we can send just a couple of cells to the lab, and they can quite accurately tell if there is the right number of chromosomes or not. Whether you do PGT or not is a personal decision, and it's a discussion to have with your doctor. And I think it's actually more than 90% accurate, but there's some gray results. It's called mosaic, and we're still not sure in 2022. What does mosaic mean? Is it just an artifact, or is it something that's intermediate and it's going to go on to be normal? So there is still some gray in the PGT, but if you get an embryo that says that it's chromosomally euploid, it most often is. Next slide, please. Who is PGT recommended for? There's a variety of reasons. The most common reason we do it is for age. Like if you're advanced age, as I said before, only 1 in 10 embryos is chromosomally normal if you're 40. So for me, I tend to recommend doing PGT for people who are 38 and older. Under 38, I have a discussion and I really present the positives and negatives and leave it up to the patient. But if I'm having someone store embryos for the future and it's their only chance to have babies, in the future, then I often will push it back to 35 and have them test from 35 and older, or sometimes I only test, say, 4 or 5 embryos, just so I know there's at least one euploid or an embryo that has the correct number of chromosomes. Next slide, please. The benefit of PGT is it counts the number of chromosomes. You will know the sex of the embryo if you want to. We don't have to tell you that. A lot of patients do not want to know the sex at the time. They just want to know that they're getting a healthy embryo back. And in older patients, it looks like it increases the chance for success and may decrease the chance for miscarriage. It also lowers what you have to do after the fact, meaning once you're pregnant. So again, when I was a resident in the 80s, women would, over the age of 35, would most often have what was called an amniocentesis, where they took water, some of the water that's around the baby, and test that. But that test wasn't done until 16 weeks of pregnancy, and that's pretty rough. You don't get the results back till 2 weeks, 1 or 2 weeks later. And you know, you're 18 weeks already, you're showing, you know, you're pregnant. Sometimes you're feeling the baby moving already when you're getting those results back. So it is nice to have that information sooner. Thankfully, there's also now what's called a non-invasive pregnancy testing that is done at about 9 weeks of pregnancy, 9 to 10 weeks of pregnancy. So you can get the information much sooner, and it's just from a blood test. And that testing is about 75% accurate. So I sort of go through all this with couples or patients when I see them, and just say, here's all your options. You decide what's best for you. Next slide, please. Reasons not to choose PGT. Well, it can be a personal thing. You might just not want to do it. You do have to biopsy the embryo. So as I showed in that picture before, you have to aspirate out a couple of those cells. It does cost money. It's somewhere around, I don't know, $4,000 currently is what the going rate is in America. It's somewhere between $3,500 and $5,000, depending on where you do it. And if you're doing PGT, you have to freeze the embryos before you use them, because it takes that long to get the testing results back. In the early days, again, of PGT in like 1995, they used to have like sort of rush results, so they would come back sooner, but that testing was considered not accurate enough. So we stopped doing that probably in around, I don't know, 2000. So most times if you're having PGT, you're freezing the embryos. Next slide, please. So it's important to set your expectations, and it really depends on age. So that's an individual discussion I have with each patient depending on their age. But say you have 12 follicles on ultrasound. You go, okay, so it looks like you're going to make, you know, somewhere between 8 and 15, 8 and 20 eggs. I make it very broad because I really like to manage expectations. And of eggs, maybe you'll get 10 mature eggs out. When we retrieve eggs, about 75% are mature. Of eggs that are mature, about 70% fertilize. So if you had 10 eggs, you're going to end up with 7 embryos. Of those things that fertilize, only about 40 to 60% will go on to that blastocyst stage. So from 10 eggs, you might only end up with 2 to 4 blastocysts. And if you test, you might only get 1 or 2 or no PGT-A normal embryo. So it's sort of, there's this huge attrition. And I really go over this in detail with patients because it's really, really important to manage your expectations. A lot of people think, oh, 10 eggs, 10 babies in the future. No, 10 eggs, probably 1 baby, if things go well. So next slide, please. Embryo transfer. So embryo transfer is when you put the embryo back into the uterus. It can be done either as a fresh embryo transfer, meaning you put it back 5 or 6 days after the eggs are taken out of the body, or it can be a frozen embryo transfer. For instance, if you're doing the PGT, or you're making these embryos for a later time, or you're too stimulated. So if a woman makes more than 15 eggs, we often will say fresh transfer is probably not that great, because that hyperstimulation thing I was talking about will get worse if you get pregnant in the cycle where you took the eggs out. So we gauge this individually by how patients are doing, but I often do a fresh embryo transfer in my cycles. Often, I would say more often than not. Next slide, please. This is just a frozen embryo transfer calendar that shows you if you're doing a cycle, like what's going to happen. You're going to have some ultrasound visits. You're going to maybe taking some hormones. If you're doing a hormone replace ones, I often do natural cycle FETs also. So there's different ways to do this, and this gets individualized. So I'm not going to go into detail with this. Next slide, please. And what happens with the embryo transfer? We use a catheter that's kind of like cooked spaghetti, actually. You can kind of, if you shake it, it actually will wiggle like, almost like a cooked spaghetti. So it's very soft. It doesn't hurt. It doesn't take 10 to 15 minutes. Sorry, I didn't edit that. It takes about a minute to do an embryo transfer. So the embryologist gets the embryo ready, but the actual transfer itself takes about 15 seconds. There's no anesthesia involved. Literally, the catheter is just passed through the cervix, and there's a syringe that allows us to just gently release the embryo from the catheter. Next slide, please. This is treatment options and success rates. So you can do intercourse with medication. You can do intercourse just trying on your own. You can do IUI with medication, meaning doing an intrauterine insemination. You can do IVF. You can do IVF with PGT. And they all have different success rates. So the thing I do really stress with patients is if you've been trying for a year and you try to do like fertility drugs with, say, an insemination or intercourse, it's only about a 10 to 15% chance that that's going to work in a given month, where in vitro fertilization, if you're 35 years old, is going to be about 50% chance of working. So we used to use, even insurance companies used to make us do 6 cycles of medicated insemination cycles before they let the patient go on to IVF. Thankfully, that's almost all gone away. And it's really up to the doctor's discretion what you do. But, we weigh it out, we discuss it. We say a lot of people are adverse to doing IVF early on. So even though it has a much higher success rate, they want to try other things first. It's a discussion you have with your doctor. And when you look at IVF success, actually, people have looked at IVF by like recurrent cycles, and each cycle works about the same, the first, second, and third cycles. But if IVF doesn't work after 3 cycles, sometimes there's something else that needs to be addressed, or maybe it can't be addressed. And that's another discussion. And it's much more common to have that discussion over the age of 40. Next slide, please. The path to parenthood is tricky. Sometimes people just fit it in as another part of their day, like, okay, I've got to go to work, I've got to eat breakfast, I got to eat lunch and dinner, and I've got to do IVF. Okay. And other people, it's really traumatic to go through the fertility experience. So we do have people to help you. And I think the resources at Kindbody just coming in, the staff is so nice and they're so helpful that I think, I was in the office all day today and the patients just say, wow, it really does work here. So I feel really good about the support that you receive during a cycle. Like I saw somebody for a pregnancy scan today and she said people were just so supportive all the way along the path. Next slide, please. And just, in completion, there's really no one formula that works for everybody. You really have to have a discussion, the doctor-patient discussion, and decide what's best for you. What are you comfortable with? What has the best chance of success? When do you want to do it? I mean, it's really different than, say, 30 years ago, like how you're counseling patients. And we welcome all kinds of patients. So whether you're a single person trying to have a child on your own, or you are 2 people and you have somebody else who's willing to donate eggs for you. I mean, it's really spreads the gamut now. Next slide, please. Whether you're trying to do things for the future or trying to do things now, a lot of patients who are coming now are really trying to see, where are they? Like I would say half of the patients I see today are just coming in to say, I'm 30, I'm 28, I just started my job, or I'm going to law school, or whatever they decide they're doing. And I just want to know, where is my fertility today? And that's a very important assessment. And we have something called a pulse right now. I don't know if I can say the price, but I think it's around $100 or something, where you can have an ultrasound and a 15-minute consult and an AMH level and figure out like where you are in your sort of fertility journey or potential. And whether you can do a pulse or not, it's really useful to get that information, just see where you are, particularly if you're not ready to have children just this minute. Next slide, please. There are Kindbody clinics in a lot of places now. It's a rapidly growing company. So there's, in the middle of the country, there's quite a bit. On the coast, there's quite a bit. Just opened a couple of clinics in the last 2 weeks. So, I mean, this is something that's really changing. So you can go on the website and see where your closest clinics are. I mean, obviously in New York City, we have both Bryant Park and Flatiron. We tend to do most of the monitoring and initial patient evaluations at Flatiron. And then we do all of the retrievals at Bryant Park because that's where the lab is. Next slide, please. I think I'm going to let Sydney talk about this one, this promo. Like, this is getting out of my range, but I hope I gave you information that helps you on your journey to achieve a pregnancy or a live birth.
Yes. So I just wanted to jump in here. Thank you so much, Dr. Noyes. And we're going to get into some of your questions because we do have a few minutes to get a little Q&A going. But I wanted everyone to see, we do have this special promo going on, as I mentioned earlier, 20% off your cycle, and as well as a complimentary initial consult. And you will be able to do this if you are self-pay. If you have a benefit with Kindbody, you can go ahead and just activate your benefit. You most likely will have the cycle covered with that benefit. So, this is really only for self-pay patients, but it's very exciting. And we will have all of this information plus the recording of this webinar in your inbox tomorrow. Very exciting. As well, I just wanted to let you know, if there's anyone on here tonight that is ready to get started, wants to get in booked right away tomorrow, I mean, not tomorrow, but in the immediate future, we can have some of our representatives, our patient care navigators will call you in the next week or so, and they will get you scheduled and you'll skip right ahead. So there's going to be a survey. Once this meeting is ended, you're going to get a survey on your screen. It's just going to ask for your name, your phone number, and your city. And our team will contact you as soon as possible to get you in and skip the line. So thank you for joining us. As a thank you for joining us tonight. So we're really excited, and I'm going to just move on and get some of your questions answered. So let's start with Dr. Noyes. I get this question comes up a lot, and this was in the chat. When you do an egg freezing cycle, an egg retrieval, sort of the beginning piece of IVF, and you extract however many eggs, is that going to deplete your egg count? Is that going to take anything away from what you've already had? Will that kind of deplete your stock, if you will, or is that something else?
Yeah, that's a really good question. And, they've done even mouse studies on this. So they've stimulated mice over and over and over again and see if they can deplete the eggs. And I think it was something like 100 times you could deplete all the eggs that were in the ovary of a mouse. But in general, you have to think of it like a needle in a haystack. So if you take 10 eggs out and you have 300,000 eggs, or even if you have 150,000 left, it's literally like a needle in a haystack. So no, it doesn't decrease your fertility to take a batch of eggs out in a given cycle.
Thank you. What about, somebody asked, if you implant one single embryo, do you have a chance of having twins?
I've written a whole paper on that. Yes, you can. It's called monozygotic or identical twinning. So some people in the past have also had conjugal relations during their cycle and had an egg that was released, get fertilized, and end up in the uterus. But most people don't do that during their cycle. So in general, if you have an embryo in the uterus, it can split. It's about 1 in 240. So it would be an identical twin, and it would be about 1 in 240 chance. And we see it in nature at that same rate as we see it in IVF.
Okay, thank you. And what would you say if a patient came in and they were wanting to do IVF and they have frozen eggs? Would you recommend using the frozen eggs over the eggs that they have currently in their body?
Well, really good questions tonight. So what I tell patients is it's a wait and see. So say someone freezes at 33 and then they come back at 40. I will usually check their AMH and their antral follicle count and see where they are. And if they're still in a really good place, sometimes I'll just say, let's try the eggs that are in your body first, in case you want to have a second child. It can be like a potato chip where you get one, you're like, okay, I want another one. So if you do get pregnant at, say, 40, you're going to probably be 42 by the time, or 43 by the time you're looking for that second child. So it kind of depends, again, what is your longer range plan? But before the age of 40, if the AMH and the antral follicle count are good, then I will go with the eggs that are in the body. And 41 and over, I tend to go with the frozen eggs first.
Great, thank you. Somebody asked, do we conduct surgery on an arcuate uterus at Kindbody?
That's an interesting question, because an arcuate uterus doesn't need to be operated on. So again, I ran reproductive surgery at one of the hospitals I worked at for 23 years. And there, I've done a lot of uterine anomaly surgery over the course of my career. And an arcuate is just a little bit of a dip. It's almost like a green trail. I'm a skier, so it's almost like a green trail in the amount of dip that's in the top of the uterus. But that arcuate is a variation of a deeper dip, like those slides we were showing before, where there's like this little, like a wedge in the middle of the uterus. And yes, absolutely, we take those wedges out for instance, in Bryant Park, I do it every week. So it's not always a septum that I'm taking out, but the last 3 weeks I've taken a septum out. So it really depends how deep that dip is, whether it needs to come out or not. If it's just a little tiny arc, we generally don't take it out, but if it's deeper, we generally do.
This is a really interesting question. So somebody asked, would low ovarian reserve necessarily indicate poor egg quality? So she said, I have low ovarian reserve at 37. Would that also indicate poor egg quality, or can you have fewer but still healthy eggs?
That is okay. You get an A, whoever asked that. That's the best question of the night, because that's a hard one. And again, you have to have the experience to answer it. Quality and quantity are two totally different things. So there are people that have low ovarian reserve and have very good eggs. And the most classic example of that is someone who has endometriosis. So that disease I was talking about, where the lining of the uterus gets out into the fallopian tubes. And then spreads around by the ovaries and inflames the ovaries and lowers the ovarian reserve in that way. And those people often have very good quality eggs. And in fact, that was one of the best candidates for IVF, even back in the 90s, because if you could get those eggs out of the body and get it away from the inflammation, we could get pregnancy. So the answer is no. Low numbers of ovarian reserve, particularly at a young age, don't mean low quality. The flip side of that is, even if you have a lot of eggs when you're, say, 45, like I have women who have come in at 45 and they have antral follicle counts of 30, the quality is the bigger problem, not the quantity. So, you have to weigh both those factors together, and age is probably the biggest determinant.
Great, thank you. Here's another great question. Great questions tonight, everybody.
Oh, really good.
Is there a difference of success with a fresh egg versus a frozen egg, or a frozen embryo versus a fresh embryo?
That's another A question. This is a good crowd. So looking at traditionally, like again, back when I first started, fresh IVF had about a 15% higher rate than frozen IVF. But as time has gone by and the freezing process for embryos has gotten better, fresh and frozen embryos have just about the exact same success rate. So whether you have a fresh or frozen embryo really depends on how many eggs are taken out of the time, what your timing is, whether you're doing PGT. So there's outside factors that decide fresh versus frozen embryo. Egg is another topic. So frozen eggs, again, I've frozen eggs for thousands of women at this point in my career, and I've thawed 1,000 women's eggs. So I don't know if 1,000, but probably I've thawed 500, something like that. And when you look at frozen eggs versus fresh eggs, less of them go to the blastocyst stage. So if you say the blastocyst stage, if you take fertilized embryos and take them to that day 5 stage, less frozen eggs will make it to the blastocyst stage than fresh. But the difference is about 15 to 20%. So say the blastocyst formation rate is 60% for a fresh egg, it's about 40% for the frozen eggs. So that's the main thing that you lose. If you take a blastocyst from a fresh egg or a frozen egg, pregnancy rate is exactly the same. So if you get to blastocyst, the pregnancy rate is the same. And even the PGT testing has been equivalent. So the beauty contest is the really important thing. Can you get to that nice blastocyst in 5 days? Mm-hmm. I know it's a complicated answer, but I hope it's helpful.
No, I think so. Okay, so I'm going to give you a couple more and then we will close up. Here is an interesting one. I actually don't know the answer to this. Do we do PRP for ovary rejuvenation to increase number of eggs?
I have no comment on that.
Okay. And let's see, is there any indicator of quality in testing or just quantity of eggs, I imagine?
Any indication of quality of ask the question again. I'm sorry, I didn't get it.
Essentially, can we test for quality of eggs?
Yes, in seeing the chromosomal complement, meaning does it have the right number of chromosomes? That's definitely a better quality embryo. It has a much higher chance of getting you pregnant. For instance, if you take an embryo that's untested, say at age 37, you're going to have about a 30% chance of pregnancy. And if you have a tested embryo and it's euploid, you have a 50% chance of pregnancy. But it just because you've screened it out, you've screened out the better embryo and put one in. If you're younger than age 35, honestly, the pregnancy rate is about the same, whether it's a tested embryo or not.
Okay, so this person is asking, just to clarify, she means before the retrieval. So I think not embryo, she's saying egg. Is there any way to understand egg quality before we make an embryo?
Wow, this is a really good group. I could have you guys every night, except for I'd be tired. The quality of the egg, no. When we get the eggs out in the dish, they actually all look the same, whether you're 25 or 40. You look at that egg in the dish, and if you put 10 eggs in front of me, I couldn't tell you the age, the quality, how they were stimulated, anything. It's literally just it's a little ball of cells, and it's got the chromosomes lined up in one place where you could see the batch of chromosomes, but you can't see the quality of them.
Great. Okay, so I think we're going to close it up there. What I'll do, if you didn't get your question answered tonight, or you think of another question, please send us a DM on Instagram. We will make sure Dr. Noyes gets it. We will get you your answers. Everyone, just so I don't know if you see Dr. Noyes, but everyone's saying thank you so much in the chat. And I'm so glad that everybody joined us tonight. And again, once I close up the session, you'll get a survey on your screen. If you are ready to move forward with treatment, one of our patient care navigators will reach out to you tomorrow. So just fill out that form if you're ready to get started. And we will make sure if you're self-pay, you'll get that promo, and we'll navigate you through otherwise with insurance or your benefit.
And I just want to say, I feel honored to be here, and I feel honored that you all came to listen. Thank you.
Taking proactive care of your health. It's amazing. Thank you all. And we're gonna get to your questions in the DMs whenever you can, and we will make sure they get answered. Thank you, everyone. And thank you, Dr. Noyes, again.
Thank you, Sydney.